hear you.
Okay. I think we should go in that same order again.
That works for me. Absolutely.
All right.
Little thing over here.
Hi,
Got
Lauren.
that doula recognition. I love to hear that. Hey.
Hello.
Are you okay if we go in the same order again?
Yeah, definitely.
Okay. Anybody want
Right.
to?
Should we give them another minute? Do we?
We can. We've got, looks like we have 20 people here.
All right. Well, I can just get started and then we can have more questions maybe. So my name is Katie Haig. I am a nurse practitioner and I recently defended my dissertation at the University of Delaware. So I'm very excited about that. And I work in the fields of infertility and reproductive endocrinology along with bioidentical hormone replacement. So a lot of specialty in women's health specifically, but my research really focuses on fertility knowledge in young women of reproductive age. And what we see in the literature is that most research participants, I would say 90% or more actually through various studies, report an interest to become pregnant in the future. They want to build families, but unfortunately, what we see is that there are significant gaps in knowledge for women of reproductive age when it comes to fertility and understanding factors that could negatively impact their fertility, like increasing age or, misunderstanding of when in your menstrual cycle you can become pregnant, the ability for current fertility treatments to be successful, things like that. And another thing that we see in the research is that women of reproductive age, when we look at this in the research, this is a huge age group. It's, usually from 18 to 49 in most research. So, understanding, me as someone who's in my 40s, we won't get specific about the age, but, I know things now that I maybe didn't know when I was 18 or 19. And so what changes occur in our own knowledge over time, and why do these gaps in knowledge actually exist? And that's really a question that I've had. And fortunately for me, the University of Delaware has said, hey, Katie, take this question and run with it. So we know that conversations regarding fertility and reproductive health should happen at every doctor visit. But we also know through the literature that these conversations aren't happening. We really should be discussing a reproductive life plan, which is just kind of what are your fertility goals? What would you like to see with every person of reproductive age? And my goal was to adapt a tool to assess fertility knowledge. And fortunately, Dr. Corkus, who is here with us, she helped me with this research. And we identified a tool that could be used in a vast background of young adults aged 18 to 24 who have various educational backgrounds. So not just for people who, have been to college, but maybe for individuals who have a high school education or different levels of education. So we found that, there is still huge gaps in knowledge for everyone across the board. And I'm hoping that with this adapted tool, healthcare providers will use it and we can encourage discussions to actually occur with young people about their reproductive health, about their future fertility plans. And we can really end up following the guidelines that are set before us to provide this excellent care. So that's really my spiel on my current research. I'm hoping to take this research even further in the future, and we are going to look at hopefully a larger population of people. Currently, we've looked at young men and women throughout the country, but I definitely like to get a very diverse group of people involved in this research and hopefully do some longer studies so I can see what changes happen once they get this education over time. So there's still a lot of work to be done, and I'm just really grateful that I had the opportunity to work with these great people and the university to make that happen.
Excellent. Thank you so much, Katie. And as we transition between the three of us, if you guys have any questions to ask us, please feel free to use the chat. We are leaving enough time at the end so that we can address those, and hopefully you can walk away with the information you're looking for. I am Jennifer Corkus. I'm a women's healthcare nurse practitioner. I am on faculty at the University of Delaware, and I teach in both the undergraduate program and the graduate program. So I help with creating baccalaureate prepared nurses and also master's and doctorally prepared nurse practitioners. So the program that I'm here to talk to you about today has been kind of alluded to a few different places. It's a definite topic of interest. We have coupled with Christiana Cares and the University of Delaware Office of Professional and Continuing Studies, and we have a birth companion certificate program. So another way to think of it is a doula, but we don't use that particular title because we are doing a localized training. And when our students graduate from this certificate program, they are recognized as doula in the Christiana Cares system. So each semester, we offer this course to either second semester sophomores, juniors, or seniors. So right now, it's just nursing students because we needed to make sure that they had some foundational background, things like nutrition, anatomy and physiology, population health, things like that give them the foundational knowledge to participate in the program. They have a semester-long program where we teach them through a certified doula from the community. They come in and teach them an intensive 2-day workshop. And we also meet with them regularly to provide further information about topics like communication and how to reinforce childbirth education and what to pack when a patient is preparing to go to labor and delivery and go to the hospital, so that these birth companions have that knowledge to share and are comfortable with that. So as the semester progresses, each student that's being trained is assigned a birth companion or a birth mother, and we anticipate that they will get to do 3 antepartum visits or prenatal visits with that mother. They can either do that in person and go with them to the appointment, or maybe meet up with them afterwards. But it's a way to establish a relationship and to help clarify any information that they may be getting along the way. And then they can help support them as they go into labor. A lot of times our birth companion students are able to help provide support, even not in person, but via text or via phone calls, to help them to be comfortable and to help labor progress before they actually do need to go in to present to labor and delivery. Then when they present to labor and delivery, that's a cue that the birth companion can head on in and provide that support. In these days, patients are allowed a support person in labor and delivery. And so a lot of times that's a partner or a family member. And then if they have a birth companion with them, that does not count against their one. So in that regard, the patient or the birth mother gets to have 2 support people in with her. So it's a little bonus. And then after delivery, the student also has a follow-up postpartum appointment with them, and kind of reinforces what happened and kind of talks about plans for the future and that sort of thing. So our goal is each semester that we are able to graduate these certified birth companions that will then stick around and continue to volunteer and support the patients at Christiana and support future classes of birth companions. So we are in our second cohort right now. Our first cohort, we graduated about 10, and this second cohort has 16 students in it, and they are progressing. I think we've had about 9 or 10 deliveries so far with this current cohort. So they're moving right along, and they are all very excited to participate. Many of them want to go on to women's health related career fields. And some of them, it's just knowledge that they can use for their own personal reference. And hopefully they will be continuing to provide that support as they finish up their nursing school. So thank you very much for listening and being here. And we're happy to answer any questions. But right now I'd like to pass it on to Lauren so she can tell you about what she's been doing.
Hi, everyone. I'm Lauren Covington. I am a pediatric ICU nurse, and I am an assistant professor at University of Delaware. And I'm going to talk to you today about my research that focuses on improving sleep health in under-resourced families and different tools we can use to help families sleep better. So 9 out of 10 children are not getting sufficient sleep. This means they're not getting adequate sleep duration at night. They're going to bed late. They're having inconsistent bedtimes from night to night. And this poor sleep in children is associated with many negative cognitive, affective, physiological, and behavioral effects, such as impaired executive functioning, increased nocturnal blood pressure, negative mood, poor dietary choices, decreased physical activity. And all of these effects individually and concurrently substantially impair health, well-being, and thriving for our children. And so the negative effects of poor sleep health and its negative health consequences are disproportionately experienced in children living in families with low socioeconomic status. And then poor sleep health in childhood, along with its negative health consequences, tracks into adolescence and adulthood. So addressing poor sleep health in children, particularly children living in under-resourced families, represents a critical public health need that could also advance efforts to ameliorate health disparities. So the reasons for poor sleep health in under-resourced families is multifactorial. The socio-ecological model helps highlight the multi-level barriers that contribute to poor sleep. For example, at the individual level, child health, such as physical or mental health disorders, can disrupt sleep. Or in younger children, having a sensitive temperament is associated with difficulty falling and staying asleep without parental intervention. And then many caregiver factors are directly associated with child's sleep, such as their own physical and emotional energy, and the ability to provide a safe and secure sleep environment for the child. And then a caregiver's own sleep schedule and ability to regulate their own sleep does directly relate to sleep regulation in the child. And we especially see this between infants and mothers. At the household level, the presence of social and partner support directly relates to better child sleep health through increased likelihood of being able to provide consistent sleep schedules for the child. Whereas on the other hand, the presence of household chaos is associated with lack of structure and bedtime routines, which is detrimental to child sleep. And then finally, at the environmental or community level, living in an urban, noisy neighborhoods with bright streetlights are associated with poor sleep quality in adults and children alike. And similarly, household overcrowding is likely in under-resourced homes, resulting in the increased likelihood of bed and or room sharing. So the presence of these factors and others that I didn't even mention, they'll all vary between families, and thus they need to be considered when providing tools to families to improve their sleep health. So I believe that addressing, and my research is showing that addressing barriers to sleep health needs to be individualized and attainable for each family. So we know that consistent bedtime routines and sleep timing are crucial for obtaining adequate sleep duration and quality on a nightly basis. So how can we help families achieve this? Well, first, we can provide education to caregivers surrounding the importance of down-regulating bedtime routines. So the American Academy of Pediatrics recommends something as simple as the 4 Bs: bath, brush, book, bed. So making sure to discuss with caregivers how, activities such as intense play or screen time will not help the child relax into sleep. And whatever activities the family decides to do, they can start them 30 minutes before bed. And then the order and the type of activities they do on a nightly basis doesn't matter as much as having that routine occur the same time on a night-to-night basis. So that's what's going to ensure an early and consistent bedtime for that child. So let's think through some scenarios that could be present and barriers to families implementing this consistent schedule. So let's say the caregiver, primary caregiver, isn't home during the child's bedtime because they're working or caring for another child or family member. We could suggest that another caregiver, such as an older sibling, grandparent, a neighbor, could step in and do the nightly routine with the child, ideally in the child's own sleep environment, but that's not always possible. Or let's say the caregiver is just maxed out in terms of their emotional and physical energy, and they don't have the patience or the ability to be emotionally available to the child during the bedtime. We can provide them with some simple mindfulness-based techniques or coping skills to deal with whatever may be stressing them out in that moment. Let's say the barrier to sleep is a result of the sleep environment. It's noisy, it's bright. We could provide a sound machine or even use a sound machine app on a phone. Blackout curtains are another quick and easy and economical fix. If the environment's too hot or cold, we can provide extra blankets or a fan for the sleeping space. If bed sharing is a necessity because of lack of room or the inability to afford a crib or a toddler bed, or even if it's just the choice of the family that they want to co-sleep, then we can provide guidelines so that they can do this in a safe way that can help decrease the risk of sudden infant death syndrome. So my take-home message here is really that we can't change all of the barriers that under-resourced families may face in regards to getting good sleep. We can't change the stressors that they face on a day-to-day basis, but we may be able to provide them with techniques to cope with such stressors and concrete solutions to deal with possible environmental issues. We can give them a toolbox of quick solutions that they can pick and choose to use on a nightly basis. This has the potential to be helpful to multiple families who face different issues when it comes to getting good sleep for their child and for themselves. And so, we thank you for the opportunity to talk to you about our different programs, and we're happy now to open it up to discussion and answer any questions you may have.
Well, I don't know about you guys, but I feel like I need to chat with Lauren for my own kids' sleep schedules and see what I can do to improve them.
I know it is really tough. And I've gained a whole different perspective on my research and my views since becoming a mom myself. And the techniques that I used to preach as a sleep researcher and as a nurse, I no longer do. I've really, getting that practical experience has totally changed my view on how I approach my nursing practice and how I approach my research as well. So it's been really worthwhile to have that.
Oh, I bet. Do you know, did they see any difference when everyone was on online learning and, around the computers more? I wonder if kids' sleep schedules changed with that. I know that's a little bit different than what you were talking about.
Yeah, no, there has been a lot of research looking at this, and they were finding, so there are kind of mixed results. So first of all, kids were going to bed a lot later because they were spending a lot more time on, devices and catching up with friends. I mean, cell phone use is really a big issue, especially in late school age kids and adolescents. But they're finding they're going to bed a lot later, but because the school schedules were not, there wasn't necessarily a set start time, especially in high school, kids could sleep later. And there's a lot of research and at the policy level advocacy in other states to push school start time, especially high school, to a later time because they're starting way too early. Kids are just not, they're just developmentally, they're not able to wake up early and function at the level that they need to learn and to, to really just function. And so they've seen huge benefits. And Colorado is one state that's done it. And they've, I think, just pushed the school start time back by like an hour or two. And it's made tremendous differences and, across all areas of health, mental health, cognitive health, and learning. And it's been really incredible. Something like a very quick, easy fix like that could have huge benefits. But yeah, so that's what they were seeing with the pandemic, is that kids were up later, but because they didn't have that set school start time necessarily, they were able to sleep in. So they were still getting adequate duration.
Oh, wow. That is really interesting.
Yeah.
Maybe we'll see changes here.
Yeah. I don't know. I mean, my research focuses more so on early childhood, but I know there's a lot of people that do research on adolescents that are really pushing. I mean, it's across the board. Scientists want the school start times to change. Yeah. So it's definitely something I'm in support of. It's just, not my personal research area.
Yeah. I'm in support of it too, but that's because I have a middle schooler.
Yeah, definitely makes a difference.
In our last session, somebody had asked a question about how the students have any kind of ability to, I don't know, not necessarily have authority, but if they are in the process of going through nursing school, then how do they answer questions and provide guidance if, they really haven't experienced things yet? And I had a text message from a colleague in the program who pointed out something that we worked on changing for this semester's cohort. And one of the things when we were teaching them about communication is listening to understand, not just listening to respond. And so we really talked about active listening and making sure that they understand what the birth mother is asking a question about or needing clarification on, because so much of the information that they need, we've shared with them and they've got that foundation. And so a lot of times just by, kind of catching their breath a little bit and trusting their nursing instinct, which, we can't teach to them, but they got to develop, they are able to pull out the right answer and, have that credibility with their birth mom. And it seems like this semester, the relationships are going much better as far as the communication is concerned. So that's definitely an adjustment that we're going to stick with.
Yeah, I mean, I think that's huge because I think that's so important to learn in nursing school, because that's such a critical, listening, not to respond, but just to truly listen is such a crucial part of being a nurse. And I think, it's just so beneficial to go into the job having that skill versus learning it, years down the road because of experiences that you have where communication isn't great with patients. So I think that's so worthwhile that the students are getting that firsthand experience as a student.
Well, and I think too, it's also helping them to kind of figure out where they want to be, or maybe even where they don't want to be, and what a great time to be able to experience labor and delivery from the other side, because when they are there in their birth companion role, they are not allowed to do vital signs or, adjust a monitor or, they cannot provide any nursing care at all because they are not there in a clinical role. They are there purely for support of that birth mother. And so, they kind of get that up close and personal. Oh, here's what really happens. And it's been an eye-opening in a lot of ways. Did anyone else have any questions or anything that we might not have thought about presenting to you, or anything that we can clarify?
Or even comments on how we could, improve our programs or our areas or things that we should consider?
Oh, that's a great question. Have you considered using retired nurses for the birth companion roles? And that is definitely one of the options that we have right now. We are just using nursing students. We haven't even opened it up to other students yet because of the clinical requirements. Even though they are not there in a clinical role, they still have to meet all of Christiana's requirements for training, immunizations, background checks, all those kind of things. So by sticking with the nursing students, they already have all of that done. And, it's kind of putting us one step ahead. But I will definitely put that in my notes and keep that in mind as we're kind of looking to expand our circles. So great idea. Thank you so much. You're right. A lot of them maintain their licenses and have fantastic experience. So that could be really good. Well, guys, we must have done such a really good job. We gave them everything they needed. Okay, so there's a question about how this Birth Companion Initiative is working to address the underserved population. And this is bringing the birth companions in for a patient population at Christiana that maybe doesn't have the resources to have a doula of their own, or to provide that additional support from their own resources. So the birth companion students, and then once they're trained, the birth companions are being provided through Christiana to the patients that are delivering there. And, as we build up the program, hopefully we can reach even more and more of the patient population. But for right now, we're still growing and developing. Katie, do you see the question about?
Oh, good. My mic is now working again. Yes. So thank you, Catherine, about that question. Actually, Dr. Judith Herman was another member on my committee and helped with my research. And I believe that she was involved with the upstream here in Delaware. So my work with her actually focused more on adolescence and, healthy relationships. Oh, Judy. Okay, great. So she's lovely. And she's been a great help to me. So that was a great question. And yes, we have been able to connect through Judy. And I just saw her last week, and she's doing, or 2 weeks ago, and she's doing great. Oh, I'm sorry you don't get to see her.
She's probably not there much.
She does travel a lot, but she is a wonderful resource. I mean, she does a lot of work. So I'll have to tell her the next time that I was connecting with you through here.
Well, I think we are the last thing between our attendees and a coffee break or a bathroom break, whatever they need. We are available later on if anybody thinks of any questions, or if you would like to chat about things, we're happy to, and we appreciate your attention. Thank you so much.
Thank you, everyone.
Feel free to reach out.
Yes.